So here in 14.2, we're going to take a more general look at how these antimicrobials work. So we're going to start with bacteriostatic versus bactericidal. So a bacteriostatic drug is one that causes reversible inhibition of growth. This means that the growth is going to restart after we take the drug away. So bacterio, right, so we're talking about bacteria, and then static. So it holds it in place, it keeps it static. So what this means is if we are administering a bacteriostatic drug, that as the person is taking the bacteriostatic drug, then it's going to halt the growth of the bacteria. So we're not trying to kill the bacteria with a bacteriostatic drug. What we're doing is just stopping it from continuing to grow. And then the hope is that if we just stop it from growing, that the person's own immune system will then come in and take over and kill off what's there while we're taking the bacteriostatic drug, which is preventing there from being more bacteria. And so then the body can just come in, take care of what's there without worrying about it growing out of control or our immune system not being able to take over. On the other hand, we have our bactericidal drug. So bacteria, again, bacteria related to bacteria, and cidal meaning kills. So our bactericidal drug is one that does kill the target bacteria. It's not going to halt its growth. I mean, it does by killing it, but it doesn't purposely halt the growth. What it does is it purposely goes in and kills the bacteria. Now, whether we use a bacteriostatic drug or whether we use a bactericidal drug is going to depend on the type of infection and the immune status of the person, of the patient. So for example, if somebody has a strong immune system, so they're, a healthy 20-something, 30-something year old, relatively healthy, relatively active, and then they get a bacterial infection, what we would likely use is a bacteriostatic drug so that when the person is taking that, it just halts the growth of the bacteria, and then their healthy immune system can come along and take care of it. And this is because, as we'll talk about in chapter 17 and 18, mostly 18, what we'll be talking about is that's actually good for our bodies, good for our immune system, because if we actively fight off an infection, then that gives us immunity long term. So rather than taking a drug, if a person has a strong immune system, typically a strong immune system, and we go in and we kill it with bactericidal drug, the body may not get the opportunity to recognize that pathogen and then have an immune system response to that pathogen that then will make it so the person is immune later on. However, if a person does not have a strong immune system, if they are immunocompromised, then we would give a bactericidal drug. So if a person is immunocompromised because they have some other pre-existing condition, or they're just generally in poor health, or they're elderly, or maybe they're very young, in that case, what we would do is we would say it's not worth trying to get the body to recognize it, to have that immune system response, because likely it wouldn't be able to help it. It'll overwhelm the system if we just simply stop the bacterial growth. So in this case, what we're going to do is we're going to go in and just start killing the bacteria and helping the immune system to get rid of it. However, if there is a life-threatening infection, then we'll give bactericidal regardless of whether the person is strong and healthy or if they're immunocompromised. So that's to make sure that it doesn't threaten the person's life, even when they are a healthy person. So then let's take a look at the spectrum of activity. So when we talk about the spectrum of activity, what we're talking about then, of course, is what it is that it's going to attack. So if we have a particular antimicrobial, if we have a narrow spectrum or a broad spectrum is what we're talking about. So as the name implies, a narrow spectrum means that it's only going to target specific subsets of bacterial pathogens. So for example, only gram-positive or only gram-negative, or maybe even only a specific genus, for example. So it's very narrow, as its name says, so a narrow spectrum antimicrobial. We would use a narrow spectrum antimicrobial really only when we have identified that pathogen. So if somebody comes in, they get a swab or a blood draw or something, and then that's sent off to the laboratory. The laboratory identifies the particular bacteria or whatever it is, and then they can come back and they say, okay, I prescribe this narrow spectrum antimicrobial because we know exactly what you're fighting off, and we know that this particular antimicrobial will fight that particular pathogen. If we don't know what it is, then likely we're going with a broad spectrum antimicrobial. And a broad spectrum antimicrobial then targets a wide variety of bacterial pathogens. So in this, for example, it could be both gram-positive and gram-negative versus the narrow, which would only be gram-positive, for example. So oftentimes a broad spectrum is given when we're waiting for lab identification. So if a person goes in and they are very, quite ill and they need to get started on something soon, then they might be given a broad spectrum, even though a blood draw or a swab or something was done and given to the laboratory. And then they're waiting on lab identification. Once they get lab identification back, then they may then switch to a narrow spectrum antimicrobial, but they've given that broad spectrum to hopefully take care of whatever it is in the meantime because it has a wide variety of pathogens it can kill. Broad spectrum antimicrobials are also given with polymicrobic infections. So this is poly meaning many, so a mixed infection with multiple bacterial species. So even if it has been identified, if it's been identified that there are multiple bacteria species, then we may still give a broad spectrum. Because in this case, we might not just have gram-positive infection, we might need to open it up further to gram-positive and negative, for example. Broad spectrum are also given as prophylactics. So that means that if somebody's going in for surgery, for example, they would give a broad spectrum antimicrobial ahead of time so that when they're in surgery, if they're exposed to any bacteria, that there's already antimicrobial medicine chemicals in their body to be able to fight off those bacteria. Or other invasive procedures. So any invasive procedure that may cause or may be putting the person at risk for a bacterial infection, then they can give it as a prophylactic, as a preventative measure. And then treat an infection when the narrow spectrum fails due to resistance. So we're going to talk about antibiotic resistance. And in the case of some of the narrow spectrum antimicrobials becoming resistant, if that particular antimicrobial is resistant, or that bacterial infection inside of the person, if that bacteria is resistant to the narrow spectrum, then we would open it up to a broad spectrum, hoping that that bacteria would also not be resistant to that. So if we talk about our broad spectrum, it sounds like, well, that's great. We can give a broad spectrum and it's just going to go in and it'll kill gram-negative, gram-positive, different types. And we can make sure we can give it ahead of time. We can give it while we're waiting for lab results. We can give it, if the narrow doesn't work out because of resistance. However, it does come with risks. All right, so for broad spectrum antimicrobials, it is going to also target our normal microbiota, and that's the biggest danger, the biggest risk, along with resistance. But the biggest risk inside of our bodies is that it will then go in and cause this death of our natural or normal microbiota. What this does is it increases the risk for superinfection. A superinfection is a secondary infection in the patient when we already have a primary infection. So the way this works is because if we have, as we know, we have our normal microbiota, say in our intestines, for example. And so we have all of these different bacteria and yeasts and all of these things that are living in our intestines, all happily living together. They're feeding on the food that we put in our bodies and our intestines, and then they're feeding off of the products of each other. They're helping us break down our nutrients so that we can utilize them, and everybody's happy. If we then accidentally get a pathogen, say we eat it, for example, and then that's going to be in our intestines, and then we go into the doctor and we get a broad spectrum antimicrobial and we start to take that, it may be killing some of that pathogenic bacteria. However, the broad spectrum antibiotics are also going to be killing the cells in our intestines, all of these ones that were happily living together off of each other's products and the stuff we're feeding, and creating our natural microbiota, which is keeping us healthy. Instead, these are going to be wiped out as well. So it's going to kill all of our protective microbiota. Remember, our normal microbiota, the reason it's protective and all these things are happily living together is because what they're doing is they are utilizing the products that we're making as nutrients. And if we have all of these different bacteria and yeast and things that are utilizing what's available, if a pathogenic bacteria comes in, it's going to have a serious lack of resources. So if we have a healthy, normal microbiota, we're eating good, healthy food, then everything will be used in the system. So there will be very little excess nutrients. There will be a good amount of waste that is not, that's constantly being gotten rid of. Things are flowing happily. Now, if a pathogenic comes in, it's not going to be able to find its niche. So it's not going to be able to find enough nutrients. If it comes in and tries to reproduce, it may not be able to handle the environment, which is good, and that's why one of the reasons why we have normal microbiota. However, if we go in then and we take a broad spectrum antimicrobial and we wipe all of that out, now our pathogenic bacteria is saying, fantastic, thanks for getting rid of all those guys for me. I have plenty of nutrients now that I can eat, and I don't have any competition. So you can see our broad spectrum antibiotics also kill these non-resistant cells that we have in our body. Our pathogenic bacteria is still hanging out in there, and then it's able to reproduce because it doesn't have any competition. So it's going to allow those those other pathogenic bacteria to proliferate. So we can see this sometimes. Sometimes that causes a yeast infection. So that's why sometimes people will take probiotics, increase the yogurt, the kombucha, take just pill form of probiotics if they're also taking antimicrobials. And that's fine because they're taking probiotics, which is continuing to replenish and put back in all of these healthy bacteria. So taking a probiotic, which is, lots of bacteria, while also taking an antimicrobial, well, perhaps you're killing a lot of what you're taking. The hope is that you are replenishing what you're also killing in your intestines. And so there's still some competition for that pathogenic bacteria. So it can't completely take over and then become resistant to that antimicrobial while wiping everything else out. We also see this with our pseudomembranous colitis, which is from Clostridium difficile. So that's C. diff, and we see that, and that can actually be fatal, which is a serious, serious concern, particularly in hospitals. So our broad spectrum, while they can be very helpful, does not come without risk. So next we're going to talk about dosage, which is just basically the amount of medication that's given. And with that, not only is it the amount, but it's also provided, or what's provided is the time interval. So with particular antimicrobials, our optimum dosage must be determined because we want to minimize our side effects, right? We just talked about those broad spectrums killing everything. But in general, we want to minimize other side effects as well while still achieving the cure. So we have to balance that. So we want to consider not only our normal microbiota, but also we could have things like allergic reactions that could cause serious side effects. There are also other potentially serious side effects that we may or may not know about. But keeping in mind that penicillin can cause allergic reactions in people, that is a serious side effect. And therefore, we need to consider the dosage. In that case, of course, typically the dosage is 0 and we go with something else. But these things need to be taken into consideration. For children, what's taken into consideration most is the patient's mass. So depending on the weight of the child is how the dosage is given. For adults and children 12 and older, there's typically just a single standard dose, regardless of the mass. And you can see this even in over-the-counter medications. If you look at over-the-counter medications, you'll often see adults and children 12 or older, this twice a day. But you'll see that anything less than that, there's typically, between 6 and 12 years old, between 2 and 6, and then under 2, and then sometimes under 6 months, or, depending on the type of over-the-counter medicine. And that same thing happens with our antimicrobials. When they are prescribed, all of these things are taken into consideration. However, in children, it's based on their mass, and that's how they get those those general guidelines. However, some experts argue that mass should be considered in all patients, which if you think about it really makes sense. It would make a lot more work for people, pharmaceuticals, doctors, things like that. However, I think we can all agree that a child that is 12 years old, for example, is likely not the same weight or size as an adult that's 50 years old that may have some health issues, may have an extra portion of weight on them, etc. So giving a 12-year-old child a healthy, active 12-year-old child, medicine, the same amount of medicine for a 50-year-old extremely overweight person does not seem to make much sense. So people argue that we really should be going by weight, by mass, rather than by age at that point. However, that's not really how we do it at this time. So some other considerations for dosage is how the drug is metabolized, how it's eliminated from the body. So sometimes there can be, if a person has liver or kidney dysfunction, then the dosage has to be adjusted. If there's a decrease in metabolism and a decrease in clearance, that has to be adjusted because it can lead to toxic levels of the drug or side effects. So a lot of things need to be taken into consideration when giving the dosage. We think oftentimes it's kind of a one-size-fits-all, which for many people it is. But if a person has pre-existing conditions, if they metabolize it differently because they have liver problems or kidney problems, which are the two places where we metabolize our toxic products, or toxic chemicals that we find in our body, of which an antimicrobial would be, then we would need to consider that. Also, there are factors specific to the drug, so depending on the drug, of course. So, for example, the half-life of the drug, which half-life, just like in chemistry, is the rate at which 50% of the drug is eliminated from the blood plasma. So half-life, meaning how long the life of half of the drug, so how long it takes for half of it to go away. So some half-lives are short, so an hour, and these would be we would know that the half-life is short if our dosage is multiple per day. Something like cough medicine, for example. I know we're talking about antimicrobials, but our over-the-counter cough medicines, if we say every 4 to 6 hours or every 6 to 8 hours, that's because it has a short half-life, and we see the same with antimicrobials. Some of them are long, like 12 hours, and so in this case you would see a dosage like giving once every 24 hours, for example, because then that's when it would be cleared from the system. And some have even longer half-lives. So this is easier for dosage. So if you can give somebody something and they only have to take it every couple of days, that's great. However, that might be concerning if it has some serious side effects. Because if the half-life is seriously a couple of days, then the large amount that you would be giving a person right up front could have some serious side effects in the body. And it will remain toxic for even longer. So some things are dose dependent. Or things are dose dependent. Some things are more effective in larger doses to provide this basic huge punch of medicine all at once. So we want to flood the system with a high amount of medicine for a short amount of time. Or we could have the opposite. We could say take a little bit over time, over a longer period of time. Keep it in the system, kind of keep it working on things. And it depends on the type of drug, it depends on the type of infection, it depends on the health of the person. And that's where dose dependence comes in. So saying like we need to get a whole bunch in the system at one time, or do we want to just kind of keep it going through the system for longer? Also, we have time dependence. So our dose dependent is when we take where something is more effective in large doses, and then our time dependent is what I was just talking about as the opposite of that, where it's more effective when we have these lower levels. So sometimes we want to give it a large dose, sometimes we want to keep it active for longer. So how are these given? I think we all kind of know these. There are 3 general ways that we administer these antimicrobials. First would be orally, so taking it by mouth. This is generally preferred. It tends to be the easiest because you can just take it home and then you take it, when you are told to. This is useful for diseases in the intestinal tract, of course, because we are swallowing it or drinking it, depending on what it is. And so it's going directly into the intestinal tract, which can be beneficial. However, that can be a problem if the problem, meaning the bacterial infection or the microbial infection, is not in the GI tract but is elsewhere. And some of our antimicrobials are not absorbed easily from the GI tract and into the blood. So oral, while ideal, may not be the best fit for some antimicrobials if we need to get them somewhere else in the body and they don't easily get from the intestinal tract to the bloodstream at that point. Second way is topically. So if it's not absorbed easily in the GI tract, sometimes ointments can be used, but typically when we are using our topical antimicrobials, that's because we're treating something topically, so a superficial skin infection. So something like our fungal infections that are on the skin would be a topical application. And the last one is parenteral. And when we are talking about parenteral, this is our intravenous or intramuscular injection. So we're actually injecting the antimicrobial into either the blood, venous, meaning in the veins, or into the muscle. So this is done when the patient is unable to take something orally. So if they are so ill, they're vomiting, or the type of infection they have causes them to vomit often. Taking it orally wouldn't help. If they're taking an oral drug and they just vomit it right up, that's not going to help. Or, for example, if the person is intubated, intubated is on a breathing machine, for example, they can't actually take it orally. So it would be helpful to put it into the veins directly or into the muscle in that case. This, however, is not easy. It's not often that somebody is doing this at their home, so it needs to be performed in a healthcare setting, which makes it more difficult to administer. It needs to be typically something that's administered less often as well. However, the plasma levels that are achieved by our intravenous administration is substantially higher than by oral or intramuscular. And I think we can understand that because if we're talking about our plasma levels, right, plasma is the blood. If we're injecting it directly into the blood, we're going to have really high amounts of the drug in the bloodstream compared to orally, where it has to go through the GI tract and then make its way to the blood, and obviously topically. But then also even intramuscularly, because it has to go through the muscle tissues and muscle cells before it reaches the plasma. So we can see the differences between these. If we look at this chart here on the right-hand side, we have our route of administration. So you can see we have oral, we have intramuscular, and we have intravenous. And so we can take a look at how the plasma concentration changes over intervals of time. So our time here, we started at T0 when the drug is given, and then we can see over time our different levels. Our plasma concentration is on this axis. So you can see at time 0 is when the drug dose is administered, and then you can see the differences between oral, which is the blue line here. You can see that it takes a bit to get in because they're going through the GI tract. Then we can see that it's going to peak in the plasma, and then it's going to slowly taper back down until it's gone. Then we can see intramuscular. Similarly, it takes a little bit of time before it's going to get into or get to the highest amounts. It takes a little bit longer for the concentration to reach its peak. However, it does better than the oral for sure. And then it tapers down as well. And then you can see then intravenously with the red, peaks very quickly because we're injecting it directly into the bloodstream, and then it's going to gradually decrease. And so again, when we're talking about our different doses and we're talking about the different types of bacteria and maybe how serious the infection is, utilizing different methods of administration is going to be important. So then lastly, what we're going to talk about in 14.2 are drug interactions briefly. So we can have synergistic combinations here, or we can have antagonistic combinations. So synergistic is when we can use two antibacterial drugs administered together, and they're going to provide an interaction that is better than either drug being administered by itself. So we can say you can take this one, and what it's going to do is it's going to attack this infection more effectively than if we just give one or the other. So two drugs may provide only bacteriostatic inhibition when they're by themselves. So if we provide one of those medications, or for example, it may just be bacteriostatic, and so it may just stop the growth of the bacteria at some particular path, and the other one could be the same. However, if both of them are given, rather than them both being bacteriostatic, working together, they can be bactericidal. So that may be better than giving some other antimicrobial that may be more dangerous to the patient, for example. So if the patient has liver issues and they can't take something that's bactericidal, but they want to try to still get that effect, then they can perhaps give two different bacteriostatic antimicrobials, and then that will actually end up being bactericidal. So they work together synergistically. On the other hand, we have antagonistic combinations. So these are going to provide harmful effects. So in this case, we have two antimicrobials, or one antimicrobial and one non-antimicrobial, so some other medication entirely different, and then they can cause a loss of drug activity. So maybe one antimicrobial is going to just completely mark off the other antimicrobial. It's going to cause them to be ineffective. Or some other medication that's already being taken can then make the antimicrobial ineffective. It'll decrease the drug activity. It may also decrease therapeutic levels. So depending on what the other antimicrobial or non-antimicrobial is, it could increase the metabolism, so it will metabolize faster, so we won't actually get the correct levels that we're looking for. Or it could cause them to eliminate the drug faster. So again, we don't get those levels that we're looking for. Also, it could increase the potential for toxicity. So if it decreases the metabolism, so whatever the other medication is, if it slows the body down, and then that's given, and then we may have these high levels for longer than are expected. And so if we have these high levels for longer than expected, maybe another dose is given when maybe it shouldn't be given, and that can then become toxic. And similarly with elimination, if the body is slow to eliminate, then we still maintain those high levels for longer. So an example of this would be antimicrobials that are absorbed most effectively in the low pH of the stomach. So if it's given orally, a lot of times it can work its way through the stomach, which has this low pH. And some of them are purposely designed to more effectively be absorbed in a low pH. So when they're given, they are in the low pH. However, if the patient takes antacids, so this would be one of these non-antimicrobials, if they take antacids, then the pH in the stomach is going to be increased. It's not going to be as acidic. And then what that's going to do is it's going to decrease the absorption of the drug. So we're not going to get the levels that we're anticipating getting. And that's why it is so incredibly important that when people go into the clinic or the doctor's office, and the doctor is going to prescribe something, that the patient is completely honest about what they're taking, even down to something like antacids. And that's why that's oftentimes specifically a question if they're taking any antacids, because as humans get older, our lower esophageal sphincter, the kind of rubber band gateway from our esophagus to our stomach, loosens. We don't have as much control over that. It becomes loose. And so oftentimes there's going to be some GERD, which is causing heartburn. And so a lot of times older people will be taking antacids. And if they don't tell the doctor that, then they can actually be decreasing the effectiveness of a lot of the pharmaceuticals that they might take for some sort of infection, which can then be incredibly dangerous because as an older person, their body is not, or their immune system may not be as effective as it could be if they were younger, for example. And so then we've got a couple of different factors to consider there. And so it's important that people be talking about those kinds of things because we do have a lot of antagonistic combinations with antimicrobials.